All right, guys. Assalamu alaikum. My name is Rida Hussain. I'm a second-year medical student, and this is my contact information. Please feel free to reach out. Today, I will be covering the lectures P23 and 24, Pulmonary Physiology. Um, it was like very spread out, but I stuck to the slides, and don't worry, I used all your diagrams. I made it in a way that you don't have to watch the recording necessarily again. So let's just get started. So these are the table of contents. This is what I will be covering today. Bismillahirrahmanirrahim. So uh, diffusion capacity concepts, factors affecting diffusing capacity, diffusion and perfusion limitation, pulmonary circulation, reflexes for VQ matching, and some questions at the very end. So let's get started. This is like a picture that was right at the start of the slides. There's not much explanation to this apart from the fact that like you have to memorize this. These questions are very low yield, but they can come. So the air-blood barrier, its thickness is 0.3 to 1 micrometers, which I like to assume is like 1 cell thick, basically, which is a necessity because oxygen has to pass through so many layers and it has to pass through those efficiently. So they have to be really thin, right? And then this is just the order of everything. You have to memorize it. There can be very generalized questions on it. So oxygen travels from the alveolar epithelium through the tissue interstitium of the lung to the capillary endothelium to the plasma layer inside the red cell membrane and then into the cytoplasm where it finally binds to hemoglobin inside the red cell cytoplasm. So this is just memorization, no concept behind it. Moving on, this is a major bulk of the lecture. So if you guys understand this, and I'm sorry to say you have to memorize these two equations, but I'll break it down for you, I promise. But if you guys understand this, you're honestly set for the rest of the lecture because it's just this one concept. Okay, so this is a key of whatever abbreviations there are. So let's start with the first formula. Before I start, do you guys see my cursor or should I change it to a pointer? We can see it. Okay, thank you so much. Okay, so because I'll be using my cursor to point out things a lot. Basically, let's start off with the first equation. V naught, which is basically diffusion rate, is dependent on diffusion capacity, which is DL, and the pressure difference. So whenever diffusion is taking place, I believe that it's like a no-brainer. Pressure gradient is always needed. Like a gradient is always needed, or else it wouldn't be considered diffusion because if both sides are equal with the molecules, then there will be no movement, no general overall movement of molecules. So a pressure gradient is required. Now let's move on to DL. DL is diffusion capacity. So what the scientists basically did is that they took everything that was unmeasurable but affects the diffusion of the gas or the diffusion rate of the gas, but it's unmeasurable and they made it into one coefficient, which is DL. So DL depends on diffusion coefficient, solubility, area of the alveolus, and the thickness of the alveolus. Now, realistically speaking, you can't go up to a patient and cut them up and be like, what's your thickness of your alveolus? So we have to assume these things. But this factor is really important in calculating. So we need to find a way to calculate it itself. But as I said, most of these quantities are unmeasurable. So how do we do that? By the way, I'll come back to this part later. Basically, what we did over here is that we rearranged the first equation, which is this one. We made DL, diffusion capacity, the subject of the equation. And basically, carbon monoxide is used to measure DL. Why is this so? Carbon monoxide was used because carbon monoxide exerts basically zero pressure when it's in the bloodstream. So basically, that is one less parameter we have to work with. So we can just cancel it out, making it easier to find out DL, right? So the diffusion rate of carbon monoxide is a fixed amount that we can measure. You don't need to know how to measure it, but it's a fixed amount. It would be given in the question if there are any questions like this, but this is just concept heavy. Okay. And then the arterial pressure of carbon monoxide is the pressure of carbon monoxide that you are giving. So you already know that value, basically. So that is how you find out DL of carbon monoxide. Now, DL of carbon monoxide is directly correlated to oxygen, the diffusion capacity of oxygen. It is, in fact, 2.3 times that of oxygen. So to find out the diffusion capacity of oxygen, you can just multiply your final value with 2.3, or you don't even have to do that. Basically, what Dr. Shem said is that since they are directly correlated, whatever, if DL of carbon monoxide increases, then there will for sure be an increase in the diffusion capacity of oxygen as well. Okay? Because the factors are very much correlated. Now, going back to this concept over here. So, as we said, DL of oxygen is 2.3 times of that of carbon monoxide. There is a similar concept for carbon dioxide. Um, Carbon dioxide is actually 20 times the value of oxygen because carbon dioxide is more soluble. That has to do with the bonding in carbon dioxide, and carbon dioxide is generally a smaller, more soluble molecule, which is easily diffusible, right? So you have to keep this in mind. There might be questions about it. So that's all. Moving forward. What are the factors that can affect diffusing capacity? There are three main factors that cause an effect on diffusing capacity. And if you guys memorize the equation, this is like light work for you. So starting off with exercise, how does exercise affect it? What exercise does is that you need more blood, you need more oxygen, right? So more vessels are recruited. The vessels that are usually collapsed and they're not carrying that much blood, they're more recruited. And then on top of that, they distend. So what is happening over here? Recruitment and then distension. So what does distension do? Distension increases the surface area and and it decreases the thickness, in fact, because the vessels, they expand. So the thickness is decreased by a very slight amount, but it does make a difference, right? So if we go back to the equation right over here, DL is equal to is directly proportional to the area. So if there is an increase in surface area, which is happening during exercise, then diffusion capacity will increase. And if thickness is decreasing, again, diffusion capacity will increase. So this is how exercise affects it. Something similar is the case for body position. What happens is that imagine a water bottle. So when the water bottle is standing, all of the water is pooled at the bottom because of gravity. So a similar case happens with us as human beings. Normally, most of the blood pools at our feet when we're standing up straight. But then when we lay down, when we lay the water bottle down as well, there is more blood distributed, okay? So what happens is that more blood is distributed to the lungs, which again causes more recruitment of the vessels, more distension of vessels, again increasing surface area, decreasing thickness, increasing diffusion capacity. Body size is pretty self-explanatory. Body size is basically if there is an increase inside, there is increase in surface area of the lungs, which causes an increase in diffusion capacity. Now, diffusion capacity can also be affected by pathological factors. The pathological factors can either be effects on the blood air barrier, or it could be the effects on the blood itself reaching the lungs. So what happens is that if there is a pathological condition like asthma or COPD or fibrosis, for example, specifically, let's take fibrosis because it's more easier to imagine. What happens in fibrosis is that it causes the walls to thicken up, which increases thickness, decreases surface area, which in turn will decrease diffusion capacity. It's very much linked to the equation if you link it back, okay? Secondly, decrease in blood volume reaching the lungs. So if there is less volume reaching the lungs, there are less carriers for oxygen molecules. So obviously this will again affect diffusion capacity. These are just some examples of the different diseases that can affect diffusion capacity. You don't have to memorize them. It's just for your information. Moving on, this is a normal graph for partial pressure of oxygen against transit time. Now, what is transit time? Transit time is basically the time needed for the blood to pass through a singular alveolus. Okay, so it's usually around 0.75 seconds. I would like you guys to remember that figure. Apart from that, I would like you guys to remember the normal values for venous partial pressure of oxygen and end capillary partial pressure of oxygen, which is 40 venous and around 100 end capillary partial pressure of oxygen. By the way, if I'm going too fast, please do let me know. Okay, this is the normal graph, right? Moving on. Again, this is the normal graph. But like over here, you can see the ideal value is that the end capillary should be equal to the alveolus partial pressure of the oxygen, but that is realistically not the case because of different factors. Oxygen is just not that great of a soluble agent and whatnot, which makes so that there is a difference in the alveolar partial pressure and the capillary partial pressure of oxygen. Okay, what that basically means, what this symbol basically means is that alveolar capillary difference of oxygen is greater than 0. So there is a difference, okay? But that is not the case for carbon dioxide, as you guys can see. Carbon dioxide, as we said earlier, it is very soluble. That makes it really easily diffusible, right? So the difference between the capillary and alveolar carbon dioxide concentration or partial pressure is 0 because it's so soluble. That is where the concept plays. Okay. Are there any questions? Okay. All right. Thank you guys. I'll move forward. So now we will be getting into limitations. So there are two specific types of limitations that I want you guys to focus on. There's diffusion limitation and there's perfusion limitation. Before we get into it, I would like to define them first. So diffusion limitation, right off the head, what does it sound like? It's basically like I would like to use an analogy. I think Dr. Shams also used it. So I would like to use buses and passengers. So in this case, buses are hemoglobin molecules and the passengers are oxygen. Okay. In diffusion limitation, what is happening is that there aren't enough passengers. There's a lot of buses, but not enough passengers, which makes it so that the buses aren't doing their job efficiently. Okay. So over here, this is the normal graph, right? This is the normal graph for normal alveolar ventilation. Over here is the graph for someone who will have low diffusion capacity, okay? So this might be people with asthma or other diseases. And then this is for someone who has an extremer disease, like maybe COPD or fibrosis, right? So these two have diffusion limitations, but it is really necessary to see where they have these limitations because at rest, this low diffusion capacity graph, the yellow one, it's normal. At the end of the day, it's normal. So these probably are the cases for people that have panic attacks or asthma attacks, basically. So at rest, their breathing is normal, but when they do strenuous activity like exercising or they're in a fight or fight situation, their lungs, they kind of fail on them and they cause diffusion limitation. So basically, there isn't enough oxygen being presented to the blood, right? And then in extremely low diffusion capacity, again, that's even worse. But my point over here was that we have to check the difference between resting conditions and exercise conditions because there are some diseases that don't show their true colors until you are actually doing strenuous, heavy exercise. Okay. And then again, at the same time, asthma, it has a normal and a partial pressure of oxygen at rest, but then at exercise, it's different, you know? The case is not the same. Moving on, there is a specific diffusion limitation that I want you to pay attention to. This is hypoxia. Okay, it's a bit of a difficulter topic. You're going to look at the graphs and you're going to say they're fairly similar. However, this one is a bit less steep. Why is that so? That is because the partial pressure of oxygen, you guys have to really pay attention to the axes, okay? The partial pressure of oxygen is nearly half that of the normal amount. So, however, the difference which we talked about over here, the difference is normal. The difference between the alveolar and capillary oxygen is normal. The partial pressure of oxygen is not normal. I can't emphasize this enough. The partial pressure is not normal. However, the difference between alveolar and capillary partial pressure of oxygen is normal. Okay, and this came in our exam, by the way, so I want you guys to focus on this, right? So again, this is diffusion limitation for hypoxia. Hypoxia specifically happens in areas that have high altitude, for example. So there is less partial pressure of oxygen in the air, there is less concentration of oxygen in the air. And even at the end of the capillary, there is not full perfusion, basically, diffusion of the oxygen. It's still not at 100 millimeter mercury. Moving on to perfusion limitation. So how I like to remember this is that whenever there is a plateau, there is perfusion limitation. What is a plateau? It's like the straight line, okay? So this straight line, the plateau, is a perfusion limitation, okay? So what is happening over here is that there are not enough buses, but there are more passengers, way more passengers than necessary, okay? So using the same analogy, too many buses, or the buses are not just fast enough, okay? But the passengers, they're way too many. The oxygen molecules, way too many, okay? But this is still a normal graph for normal alveolar ventilation, right? But over here, this is called perfusion limitation. So let's get into different gases. We discussed about the partial pressure of oxygen. Let's get into nitrous oxide. So right off the bat, what do you guys think this is? It's on the diagram. I would like you guys to answer this, please. All right. Yeah, perfect. Thank you, Mohammed. This is perfusion limitation. Why is that so? Nitrous oxide is, again, like carbon dioxide, it's very soluble. So it diffuses really fast. It gets into the blood really fast, but then there isn't enough carriers for it to keep on diffusing into the blood, if that makes sense. Okay. And again, there's a straight line, so it's perfusion limitation. They can just give you guys the graph and ask what limitation is this. Okay. Moving on, the case for carbon monoxide is, however, the opposite, and I'll get into that. It's a bit more of a tricky concept. Okay, so carbon monoxide, I told you guys it has a really high affinity for hemoglobin molecules. However, this isn't the case over here. Carbon monoxide, as we said before, when we were calculating diffusion capacity, carbon monoxide has basically no pressure difference, right? So if there is no pressure gradient in the first place, then there will be no diffusion. So let's go back to the equation again. So as I said over here, if delta P isn't even there, there will be very less diffusion of the gas. So even though the gas is present, the carriers are also present, there is less diffusion because solely of the pressure difference. But this is basically diffusion limitation. So I would like to again reiterate on the fact that like whatever is on the vertical axis will be diffusion limitation, whatever's on the horizontal axis, like the straight line on the horizontal axis, that will be perfusion limitation. So this was the bulk of the lecture. This is just a summary. You guys can go over it. I'll just skip it. Now we're gonna move on to some easier concepts. It's a bit all over the place, but please do let me know if you guys have any questions. So let's start off with this. Dr. Shams also spent like 10 whole minutes, 10, 15 minutes on this slide, so I want you guys to pay attention. This is basically the differences between two circulations. Do you guys think that there is a difference between pulmonary and systemic circulation? Yes. Okay. Why is that so? To save you guys some time, I'll just say because uh the pulmonary circuit isn't supplying too many organs, it's just supplying blood to the lungs, so it doesn't need that much pressure. So there is a very huge pressure difference. So I want you guys to focus on the figures. If you could memorize them, that would be very good, because this is just the normal blood pressure. This is 120/80. And then if you could memorize this, that would be great as well. So basically, systemic circulation is supplying all the organs, pulmonary circulation, only the lungs. So there is a huge pressure difference. But however, is flow different? No, flow is not different. What is flow? Flow is basically cardiac output. Flow cannot be different. Okay. But then what is flow? Flow is basically delta P over total pulmonary resistance, right? In the case of pulmonary system, right? So delta P over resistance. So how do we make sure that the cardiac output for pulmonary system is still like constant and the same as the systemic circulation? We instead decrease the resistance as well. So if the pressure is already low, we talked about this, then we decrease the resistance as well. That will result in a normal or the same cardiac output as the systemic circulation. And the cardiac output or the flow cannot be different from the pulmonary circuit and the systemic circuit. Okay. And another thing I would like you guys to pay attention to is that the difference between the pulmonary circulation and the systemic circulation is that in the systemic circulation, there is not passive regulation. Like in the pulmonary circulation, there's passive regulation of the resistance. Why is that so? Dr. Shum said it's because that arterioles, there are no proper arterioles in the pulmonary circuit, which means that like in the systemic circulation, I think you guys already learned, where does most of the resistance be controlled by? It's controlled by the arterioles, right? When arterioles aren't properly present in the pulmonary circulation, there isn't like active control of the resistance. It's more of a passive control by like factors like gravity and whatnot, but there is an exception to it. So I'll get into that later. Moving on. So I want you guys to also remember this. Remember the name Swan Gans catheter. It might come in your OSPE. It can. This catheter is basically used to measure wedge pressure, right? It can be inserted through the femoral artery or the jugular vein. Basically, what happens is that it's fed through the right atrium into the right ventricle into the pulmonary artery, where it can measure all of these pressures. So it can measure the pressure inside the right atrium, the right ventricle, and the pulmonary artery. And then when you inflate the balloon attached to the end of the catheter, you can measure the pressure of the left atrium as well, when the left atrium is all the way over here, but the pulmonary artery can give you an idea of the left atrial pressure, which is also known as wedge pressure. So please note the names Swan Gans catheter and wedge pressure. Okay, this is used to diagnose different pathologies such as mitral valve stenosis or congestive heart failure. Moving on, the only concept over here, we already covered it, by the way, we already covered it through the exercise part, right? The recruitment and distension. The only new point over here is that as pulmonary arterial pressure increases, the pulmonary vascular resistance decreases. Why is that so? So pulmonary artery pressure increases. Why does that happen? Because the blood volume increases, right? So there's more recruitment, there is more distension. So arterial pressure increases. However, because there is more distension, surface area increases, thickness decreases, there is less resistance because since the lumen of the capillary itself has increased, there is less friction between the blood and the walls of the capillary, if that makes sense. Moving on. Now we're going to be talking about the passive forces that affect resistance in the pulmonary circuit. This is really important and especially this graph. This graph has come in so many different contexts in our exam. I really want you guys to memorize it, okay? I'll give you guys an idea of how the questions come at the end, okay? So as we said, the pulmonary circuit doesn't really have arterioles, but it has alveolar vessels and extra-alveolar vessels, which are very self-explanatory by the name itself, okay? Alveolar vessels are basically wedged in between alveoli, so it's over here. And the extra-alveolar vessels are in spaces that are not that much in contact with the alveolus, okay? It's like the alveoli are two balloons, and when they expand, they cause the alveolar vessels to shut, okay? Which means that they increase the resistance in the alveolar vessels. While doing so, they make more space for extra-alveolar vessels. There's more space for them to expand, and they do distend, okay? Which causes the extra-alveolar vessel resistance to decrease. So it's indirectly proportional. When alveolar vessels, the resistance is increasing, the extra-alveolar vessels, their resistance is decreasing. So basically what happens, again, I'm going to repeat it because this is a really important concept. You're breathing in, air, it goes into your alveolus, and the alveoli, they expand together, and there's basically like a blood vessel in between the two alveoli, which causes it to shut, right? Increasing resistance, right? But the extra alveolar vessels, they have less resistance as the air gets more filled up in the alveolus, if that makes sense. So pay attention to this. Total vascular resistance is lowest at FRC and roughly highest at residual volume. Okay, what does that mean? The total graph line is this, the blue one. So the lowest resistance is at FRC, which you can see over here. This is the lowest resistance, but it's roughly the highest at residual volume. Does that make sense? So you guys have to memorize this as well. So for the case of alveolar vessels, where is the highest resistance? Where would you guys say? Good, really good. TLC. And the lowest resistance is at functional residual capacity, which is FRC. It is the complete opposite case for extra alveolar vessels. The lowest resistance is at TLC, and the highest resistance is at residual volume. Wait, I think I said that alveolar vessels have the least resistance at FRC. I was wrong. I meant residual volume. If you guys want me to repeat that, please do let me know. Yeah. All good? Okay, I'll repeat it. Basically break down the graph. Okay, so let's start with this statement again. Total vascular resistance, the total graph line is the blue one, is lowest at FRC. So the resistance is this line, okay? The y-axis, the resistance is lowest at FRC for total vascular resistance. Total means the sum of alveolar and extra-alveolar resistance, okay? And then it is roughly the highest at residual volume. So if you track the graph up, the highest resistance, as you can see from the y-axis, the highest resistance is at residual volume for total resistance. However, for like alveolar and extra alveolar vessels, there is like a different graph, okay? So alveolar vessels, the highest resistance is at total lung capacity, TLC. The lowest resistance is at residual volume, okay? For extra alveolar, it's the complete opposite. The highest resistance is that residual volume, highest resistance, okay? The lowest resistance is that TLC. It's something that you guys just have to memorize, all right? Is that fine? Should I move on? Yep, okay. Thank you so much for responding. Moving on. You're at the very end, don't worry, guys. So I told you guys there is an exception to the passive forces. There is a non-passive force, which is regarding hypoxia. So again, I told you guys hypoxia mainly happens in high altitudes. What is hypoxia? Less oxygen, right? There are two types of hypoxia. There's regional and generalized. Let's discuss regional first. Regional is basically only some alveoli are affected. So only one of the alveolus is affected from these two, right? There's hypoxia. So the blood says to itself that, oh, I sense low oxygen over here. So I'm going to direct my blood towards somewhere that has more ventilation, more air coming through, which is to this alveolus. As you can see, the blood vessel over here is a bit like thinned out, right? But over here it's thickened. So it redirects the blood to areas that have more ventilation. However, in generalized hypoxia, what happens is that there's hypoxia everywhere in every alveolus, right? So basically now where does the blood vessel direct its like blood to? It can't. So this causes hypertension because there is ultimately constriction of blood vessels in every single alveolus because of the hypoxia, because of the less oxygen in the blood. Okay. And this causes pulmonary hypertension, which eventually leads to pulmonary edema. And this is a specific case related to high altitude. It's called HAPE, high altitude pulmonary edema. Again, there's a lot of hypoxia because of the environment. There's less concentration of oxygen in high altitudes. Because of the hypoxia, the blood vessels constrict, causing increased hypertension because there's like less, thinner blood vessels. Hypertension increases, which causes fluid to build up in the lungs, which is pulmonary edema. Does that make sense? Yeah, okay. Moreover, how this works is that basically, this is mediated by potassium voltage gated channels. So it senses that the blood senses that there is less oxygen, right? It opens up potassium voltage gated channels, which causes further reactions, causes the release of calcium channels, calcium ions through calcium channels, which cause muscle contraction, smooth muscle contraction, because there's smooth muscles in the vessels, which causes the constriction of the vessel. That's all, okay? This concept is a continuation of that. So, but I want you guys to focus in blood. The blood vessels are controlled by oxygen, and in the lungs, the bronchioles and the alveoli, their constriction is controlled by carbon dioxide. So in blood, I told you already what happens is that there's hypoxia. The blood senses that there is low oxygen, and it causes the blood vessel to shrink up and give the blood to areas that there is more ventilation. So over here, as you can see from the area there, the arrow, there is less ventilation over here. The blood vessel senses that there is hypoxia over here, and it causes this blood vessel to shrinken up and this one to thicken up because this has more ventilation. We already discussed this over here. Okay, same concept. A similar concept applies for bronchioles and alveoli. The alveoli, however, depend on carbon dioxide. They don't depend on oxygen. The blood relies on oxygen. The alveoli depend on decrease in carbon dioxide. So if there is more ventilation, that means there is increased oxygen, but there is decreased carbon monoxide, which is called hypocapnia or hypocapnic, okay? So the alveolus senses that there's a lot of ventilation in me, right? Because there is very less carbon dioxide. So it causes bronchoconstriction so that air is directed towards areas that have lesser ventilation. So it's like a compensatory type of mechanism. Does that make sense? Should I move on? Again, it's really, really important to know that the blood relies on less O2, and the alveoli themselves, they rely on less carbon dioxide. It's really important. Don't get the gases mixed up. Okay, we're almost at the end, 2 more slides left. So this is really important again. The lung is divided into different zones, and this causes basically why it's divided into different zones is because of the pressure difference. So at the very top of the lungs, the alveolar pressure is the highest. So I want you guys to focus on this. What this means is that the pressure in the alveolus is greater than the pressure in the arterial side of the capillary, which is greater than the venous side of the capillary. This is the venous side, by the way, and this is the arterial side, okay? So the alveolus, it has so much pressure that it's constricting the blood vessels shut. It overpowers both the arterial and the venous side, okay? Then in the middle, so there is zero perfusion over here. It's really important. So over here, you can see zero perfusion in zone 1. In zone 2, there's a bit of a difference. There's more perfusion because now the alveolar pressure is overpowered by the arterial. So what that means is that the arterial pressure is higher than the alveolar pressure. However, the alveolar pressure is still greater than the venous pressure. So the capillary is only constricted towards the end, as you can see over here. It's not fully shut because the arterial pressure is still higher than the alveolar one, but it is shut towards the end. So there is perfusion, but not to the maximum capacity. However, at zone 3, there's perfusion to the maximum capacity because both arterial side and the venous side of the capillary, the pressure in both of them overpowers the pressure in the alveolus. Is this concept clear? Yeah. Okay, perfect. And then this is just a very small concept. Dr. Shams didn't shed that much light into it, but I want you guys to know these two names, bronchial veins and Babesian veins. So first off, I want to tell you what anatomical shunts are. Anatomical shunts are basically where the deoxygenated blood and oxygenated blood directly mix, like when they're not supposed to be mixing directly, okay? But there are, again, normal shunts and abnormal shunts. Normal shunts are always right to left shunts, right to left, LR. Normal is always LR. So it's written in the name normal. R is before L, right to left. Okay, that's how I remember it. It's stupid, but it works. Okay, so the lung supplies oxygen to the blood, but the lung also needs fresh oxygenated blood itself. How is that done? That is done through bronchial vessels. So now these bronchial vessels, they supply the lungs, and then they also have to be emptied out. So they empty out directly into the fresh blood circulation, which is in the pulmonary vein when it's returning back to the heart. Something similar happens to the heart. Again, the heart supplies fresh blood to the rest of the body, but again, it needs blood supply specifically in the left ventricle because, you know, the left ventricle is doing the most of the work. Where is the left ventricle supplied from? It's supplied from the Babesian vessels, okay? The Babesian vessels supply the blood with the heart with fresh oxygenated blood, and then it empties out directly into the left ventricle. So these are normal anatomical shunts. The not normal ones are 4 types. Dr. Shams said that you guys covered it in your embryo lectures, which I'm sure you did, but the 4 different types are patent foramen ovale, patent ductus arteriosus, the ventricular septal defect, and the pulmonary AV fistula, right? These are abnormal anatomical shunts that happen congenitally or due to different reasons. And another difference is that they can both be right and left or left or right shunts. Does that make sense? Okay, perfect. Thank you guys for being so interactive. We're done. I just have 2 questions for you guys, and I would prefer it if you guys answer it. So where is the extra-alveolar resistance the lowest? This is the graph that I emphasize the highest on. Perfect. Yes, safe. It's A. Yeah, perfect. It's A. So let me just get into the details of it. Again, extra-alveolar resistance is the lowest. So we go to the graph. Extra-alveolar is the purple one. Extra-alveolar resistance is the lowest at total lung capacity. Okay, so the answer is A. Amazing. Next, this question. If the patient has low arterial partial pressure of oxygen, but high arterial carbon dioxide partial pressure, and alveolar arterial difference is normal, what is the problem? Again, I want to reiterate that alveolar arterial difference is this concept that we talked about, the difference between the alveolus and the capillary difference of oxygen partial pressure. It's normal. A, you're right. Thank you, Miriam. You're right. Yeah, perfect, perfect. Thank you guys. Okay, so I'll explain it because you guys were a bit confused. The mechanism behind it is like basically this weird graph. Again, they said that AC difference of oxygen is normal, okay? Um, but the partial pressure is less. So you guys just need to memorize this graph. It would be better if you guys memorize this graph. So what's happening over here is hypoxia or hyperventilation, same thing. Does that make sense? Yep. Thank you guys so much. Please, please, please pay attention to the graphs. Like, please do. Okay. And if you can, please fill out the feedback report. And that's just my autistic way of saying thank you. Feel free to reach out anytime. That's all. Thank you.